Hello friends, welcome to Health, Music and Fitness channel. Thank you for visiting our vlog again. This is ECG Vlog number 12. In this vlog also we will be discussing one of the instances of myocardial infarction and any other abnormality also in the ECG that we'll see. At this point I request you to subscribe to our channel if you haven't done already, and like our videos, share our videos, also click the bell notification icon so that you can be notified of all the videos which we upload. Look at the rate, rhythm and axis, and before that always look at the calibration. In this ECG there is no calibration, it's not shown, but we'll just presume the calibration is normal. So first we'll see the heart rate. There are roughly around 4 big squares between 2 RR intervals, so the heart rate is around 75. If you want to be very accurate, you divide 1500 by number of small squares between 2 RR intervals. But on an average, in rough, the heart rate is around 75. Okay, so after the heart rate, we'll look at the rhythm. Is the rhythm sinus, normal sinus rhythm? Is it coming from the SA node, or is the rhythm arising from the atrium or the bundle of or the AV node or the ventricles? If the rhythm is arising from ventricles, there will be no P wave, or there might be a retrogradely conducted P wave. In that case, you will see a positive P wave in AVR. I had told you before, by default in AVR all the complexes are negative. P is inverted, QRS is inverted, T is inverted, and if something is upright in AVR, means something is wrong. So you reassess the ECG, reevaluate the ECG, and you have to think out of the box. And for a normal sinus rhythm, the P wave has to be of normal shape and duration, and it has to be healthy looking, and all the P waves, they should be of similar shape, size and duration, and every P wave should be followed by a QRS complex. So in this ECG you see there is a normal sinus rhythm, the P wave is good looking, and there is a QRS following the P wave, and it's occurring regularly. There are no abnormal P waves in between, and if there were abnormal P waves, we'll assess them. Most usually they are ectopics, atrial ectopics, supraventricular ectopics. So heart rate is around 75 beats per minute, and it's a normal sinus rhythm. Then you look at the axis. For axis, I had told you, you look in lead 1 and AVL, and you see the QRS complexes, see if the R wave is taller or the S wave is deeper, and you minus from the taller or deeper, you minus from that the lesser one. In this lead 1 you can see there is a tall R wave, but there is no S wave, so lead 1 is positive, there is only R wave, nothing to minus from the R wave. Then look in lead AVF. AVF is also positive, there is no S wave. So lead 1 you plot at 0 degree, and AVF you plot at plus 90 degree. We'll remember that, recall that circle, and positive pole of lead 1 is at 0 degree, and the positive pole of AVF is at plus 90 degree. So it is a normal quadrant in which the axis is there lying, and that's about the axis. Then this is another ECG example of myocardial infarction. Now you look at the ST segment and the T waves and any pathological Q wave in any of the leads. If it is there, then you think of the other leads which are looking at that particular area, and you try to look for those changes. In this ECG you can see there is ST elevation and coving in lead V1, V2, V3, V4 and V5. So it is an anterior wall MI. If these changes were between V5, V6, that would have been a lateral wall MI or apical MI, and if these changes were from V1 to V6, it would have been anterior wall MI, and if these changes were only in lead 1 and AVL, that would have been high lateral MI. and if the changes were from lead 1 AVL V1 to V6, that would have been extensive anterior wall MI, and if the changes were of extensive anterior wall MI plus ST elevation in lead 2 3 AVF, then it would have been sort of a global MI, inferior and anterior. And whenever there is inferior MI, I have told you, you have to look for posterior wall MI and right ventricular infarction. So in this ECG, there is ST elevation from V1 to V5. So it is a anterior wall MI. Had these changes been in lead V5, V6, lead 1 AVL, maybe the axis would have changed and it would have caused right axis deviation, because these leads are looking at the lateral wall towards the left ventricle, and if there is MI, you can imagine the positivity of that area is decreased, the myocardium has necrosed and the positivity decreases. So automatically if lead 1 becomes negative, you plot AVF at positive pole, so then it would have been right axis deviation. In inferior MI, look for a left axis deviation. But mind you, these axis changes in myocardial infarction, they are very susceptible to changes as the MI evolves and resolves or becomes worsen, because sometimes these patients can infarct. A patient coming with anterior wall MI can infarct in the inferior territory. They can have inferior wall MI the next day, even after thrombolysis. So the axis will change again, and these patients they might develop left anterior hemiblock, left posterior fascicular block, or LBB or RBB, and accordingly the axis will change. So you have to keep this in mind when you comment on the axis change, axis deviation in setting of acute MI. So that's it about in this ECG. Thank you for watching the ECG. It was a short ECG. Please subscribe to our channel and hit the like button, comment, and if you have any requests about any particular topic you want me to cover, please post in the comments. I'll try to see if I can update you on the topic. Thank you.